Hello, hello, good afternoon. I am super excited to be here with you today. We are going to dive into some treatment planning. So, if treatment planning is, where you're really lacking and you're looking to get a little more streamlined and you just really want to understand what's going on, you're in the right spot. Okay. So, myofunctional therapy treatment planning. I always start out with a hi, hello, and a welcome. I want to make sure everybody can see me, that you can hear me. So, please, if you're here, just in the chat, throw a hi, hello, tell me where you're from, whatever you want to put in the chat, but something that's like, hey, I see you. I'm able to hear you. That way I know I'm not talking out into the void. I am Carice Laguerre. I am your Myo best friend. I am here every single week or most weeks and giving you lots of free and useful information in Myo. I'm probably the most truthful person out there in Myo. I'm telling you things that absolutely don't benefit me and in most ways are going to incredibly benefit you. And so I'm happy to be here with you, sharing every week, but we can't keep this going unless we actually get the word out and we keep like the algorithm aware that this is something that needs to be put out there. So to help your peers, to help your colleagues, and to help yourself, it's really good to subscribe. If you're watching me on YouTube, subscribe to the channel. That way you get all the news when I'm going live, what it's going to be about. Like you get it first, okay? Because these are never like on a consistent day and time. My schedule is absolutely outrageous. And so, I don't even know when the next one's going to happen, but I know it's going to happen. I'll be here. So make sure you subscribe, turn on those notifications. That's how you are getting aware of what's happening and when it's happening. Comment, that expands reach. If you're watching on LinkedIn, the comments expand the reach. Put something in the chat. Okay. Like it, share it. Let's thrive. Let's keep this going and let's keep the community, as vibrant as possible. Okay. All right, guys. So, this is where some people who are here wind up. I do a lot of calls and a lot of talks and a lot of chats where I am speaking with people who have finished a course, who are thinking about taking a course, who have been practicing Myo for some years, or anywhere in the span of the OMT journey. And what I find is that there are certain courses, and I know exactly which ones, that do cookie cutter teaching. They teach a cookie cutter program. That program is for absolutely everyone. Visit one is visit one for everyone. Visit seven's visit seven. Visit eight's visit eight. And what really like grinds my gears is when I get certain emails, messages, when I'm on a call with somebody and they're like, hey, I'm stuck on this case. I'm on visit seven, and we haven't been able to get them to do insert basic task here. How did we get to visit seven? What have you been doing? And what exactly does visit seven mean? Like, oh no, I did everything that I was supposed to do. Visit one, two, three, four, five, and six. Okay, I don't know what that means. Like, where did you find this person? Like, where were they when you started? How are you treatment planning to get them to where you got to with visit seven? Or is visit seven the same no matter how they present? It's always confusing to me that there's a lot of times where visit seven is the same no matter how they present. Visit 8, 9, 10, 11, 12, like it just goes through a certain sequence. And then this goes on for a certain number of times. And we just assume that this is all okay in the industry. And we keep recommending these courses to our friends and our colleagues because we're like, bah, it mostly works sometimes. Well, you're wrong. It doesn't actually work. And a lot of times you're going to find that you're creating some problems in some and you're not resolving all the problems in most. So you finish a course and you don't have any structure. You have absolutely no protocols. You just know that you have to do this sequence of events. Now, this sequence is not a structure. It's not a structure. It's just a set of exercises. Or if you do have some structure, you're like, oh, but it's the same thing. I just do it for everybody, and you really don't understand how to custom treatment plan. It's okay. You're in the right space, okay? You cannot be a myofunctional therapist, and I will stand firmly on this soapbox. You cannot be a myofunctional therapist and you don't know how to therapeutically deal with the issues that are presented to you. Otherwise, you are just somebody who is distributing, your myofunctional distributor of an exercise sequence, program, whatever. So we've got to step into the next stage, and that's what we're going to talk about here, because there's two truths that are very, very evident. Same things don't work for everyone, particularly with regards to musculature. Now, anytime that I am talking to somebody for a consultation, or if I'm on a podcast, no matter what I'm doing, when I'm talking about myo, how I'm talking about myo, I always liken it to personal training. There was a wonderful live that I did where I really compared and I really debunked that whole physical therapist analogy. And it's better if you analogize it. I don't know what the word is, but don't worry about that right now. If you make the analogy to personal training, more people can conceptually understand muscles from shoulders down. Okay. If I would like six pack abs, and I feel like I've said this sometime recently too, so I've probably had it on a multiple number of lives. But if I would like six pack abs, I can't just follow the same sequence that worked for Susie. I might not have the same lifestyle as Susie, the same diet, the same routine, the same environment upon which I can do this. I might not have the same strength or skills in my musculature. I can't just do sit-ups, 100 sit-ups every day and expect to get six-pack abs and to spot locate or spot develop this certain area. We know that that doesn't work. We're very well aware that that doesn't work. We know we have to work like the whole body, and then as a whole, we can start spot training after we've kind of gotten to a certain point. And we're all very conceptually aware of this. Nobody goes on YouTube, just looks for some ab exercises, and then does that same ab routine and video every single day. And if you do that same routine and video, how long does that last you, and how long do you keep those results? Because what we're looking for in myofunctional therapy is neuromuscular re-education. We're trying to repattern how they function. You cannot habituate something that is just doop, doop, doop. Just do this a couple of times, and do this for the rest of your life. This couple set of exercises, because I have no idea what they do, and I'm just going to assume that this couple set of exercises is the way to go. The same things do not work for everybody. With musculature, people have different muscular strengths, muscular strains, muscular tension, muscular capabilities. You can't expect your treatment plan to work the same for everybody when they've got different bodies. We all have different bodies. Our genetics, our lifestyles, our diets, our choices, like we're entirely different people. We all bleed the same, yes, but we don't all develop the same, and we can't remediate the same. The second truth is that there's no room for change without a system, and we all know that in multiple ways, in multiple categories of your life. If you don't have a system around something, you have no idea where things are going wrong, and so you don't know how to change it positively or negatively. You don't know how to change or remove things from your system to then create a more positive change for growth, for improvement, for more results, for expediency. You have no idea how to do any of that if you don't have a system. So you have to have a system. You should have a sequence. You should have an order of operations, or whatever you want to call it. You should have a way that you can consistently review back and say, oh, okay, I know where I went wrong. I skipped this step, or I didn't get all of the outcomes that I needed to get in this particular step. And so this is where I have to go back to in order to get that person over the hump and then move on with the rest of the sequence. So these two truths are really going to outline for you just life as a myofunctional therapist. You can't expect the same thing that worked for Susie is going to work for Jane. And the same thing that worked for Susie and Jane might not be the thing that works for Emily. And if I don't know what I did as I was building up to how I was getting to habituation for Susie, Jane, and Emily, I can't replicate the results in order to say that I am like a therapeutic specialist or provider for this person. Okay. You have to have a system, must have a system. I could go much deeper into that. I choose not to. Okay. A couple of lives ago, when I talked about abbreviated Myo, I introduced this slide, and then that's why we have this whole lecture, because I've gotten a lot of different questions about this. Like, how exactly do you do your steps? My like order of operations, and how exactly does this work? I promise you, I'm going to explain it. We're going to explain it in detail at the end. But I think it's really important that we really start from square one. So let's start and give you guys a foundation, okay? Because there are certain principles of treatment planning that I need you to know and I need you to understand if we're going to get to our end goal, okay? One, so there's three parts of this, right? You do your evaluation. And if you do a cookie cutter program and you do an evaluation, I really have to ask the biggest question in the room. The elephant in the room is why? Why do you do an evaluation if you're going to do the same program for everybody? What does it matter? If you're trusting in that program to get them results no matter where they start, skip straight to it then. Don't do an evaluation. Just skip straight through, because you're just trusting that this thing is going to work out for everybody. You're wasting their time, you're wasting your time, you're wasting their money in an evaluation. So cut that part out if you plan to keep up with your cookie cutter programs. But if you're going to do an evaluation, your evaluation is creating a picture for you. And you have to understand what you're looking for and what you're going to do with this information. Because if you're going to collect information about an individual, be prepared to do something about it. So whether or not you're able to resolve that information, let's say you're taking measurements, intermolar width, you're looking at the space for the tongue and so forth, you're looking at structural, but you're like, I'm a myofunctional therapist, I can't do anything about it. You can give them a recommendation to somebody who can do orthognathic surgery, who can do orthotropic appliances, a forwardontic appliance, an airway focused appliance, a rapid palatal expander, orthodontics, traditional orthodontics. You can send them to somebody. So you're collecting information so that you can understand what you're going to do with it, right? So in that way, that makes sense. We're going to break it down a little more, right? The next step, construction. You're going to now build a plan. And I think of it as Legos. I always explain it to prospective clients and people that I'm going to work with. Myo is like a building block. It builds on itself. We have to start out with the foundation. Then we're going to start coordinating and really getting to remediation. And now we're going into habituation. So how are you going to construct that? What is your ultimate goal? If your goal is habituation, how are you getting there? What's your reverse engineered process? And it can't just be following sequences for appointments 1 through 12. It should be based on what you found, where you want to get to, how you're going to get there. We'll expand on that too. Planning a sequence of your protocol, like how you're going to do this. Where are you going to put all the pieces together in your deconstructed plan? Okay, so let's dive in. All three of those principles we're going to dive in. And if I lose you at any point in time, please let me know in the comments. Okay, please let me know. That way I can go back over a concept, or we can go back over something and just make sure it's incredibly clear. Don't want to lose anybody. All right, just let me know you're still with me. Evaluation. When you're doing your evaluation, you're looking at all the oral facial function. You're looking at the oral facial function of the entire complex, right? Your muscles of mastication, muscles of facial expression, oral pharyngeal, velopharyngeal space, your soft palate, your tongue, your lips, your cheeks. You're looking at all of that function. And you're identifying what's within normal limits and what's outside of that. So outside of that might be any sort of asymmetries, any overdeveloped, any underdevelopment, any compensations, and recruitments. So you're looking at all of that and you're going to collect this information. But what's the final outcome when you have asymmetry? Final outcome, in my words, in my opinion, when you have asymmetry, is to establish symmetry. So if I've got an overdeveloped masseter and my masseter is more overdeveloped on the left, super prominent, comes all the way out, and it's just a little bit less on the right, I want to balance that out. If they're both really overdeveloped, like it's super prominent, most likely you're going to assume that there is some form of either a chewing habit and it's a lot on that side, or unilateral mastication. It's mostly on whatever side you're getting the asymmetry on. So you want to wind down on the overdevelopment. You want to bring it down. Balance, and then overdevelopment, underdevelopment, you're either bringing up and strengthening the musculature or winding down and relieving some of the musculature from the detrimental impact of parafunctional habits or compensations and recruitments that exist. So compensation and recruitment, your final outcome, you want to eliminate those. So take a look at your evaluations. And if you have one in front of you because you're ready for this, or you have somebody in mind because you were ready for this lecture, I want you to just look back at what you found. Where there was asymmetry, what's your plan specific to that bit of musculature? How are you getting to where you want to get there? What's your plan for compensations, compensatory patterns you found, or recruitments? How are you going to remediate those? And it's never just one simple thing. And trust me, I've got an example. We'll get there in just a second. But I want you to start analyzing it very therapeutically. Think about what it is that you are witnessing, what it is you have discovered, and what the next step should be to get to your ultimate goal. With that in mind, okay, let's talk about construction for a second. Because in order to create that plan, you're going to have to understand like what goals are, what goals exist, what goals you should be aiming for. So, what are the realistic goals? Is it establishing proper oral resting posture? Is it eliminating compensatory patterns? Is it enhancing strength and awareness? Is it assisting with tether or tissue preparedness, surgical wound management, healing outcomes, and functional remediation? If you want to establish proper oral resting posture, and this is not a comprehensive list of goals. I've got a lot of goals that I list on a treatment plan and an evaluation report. I have a lot of lists. But understand what your goals are, and these are some of the most common ones. Establishing proper oral resting posture. What does that consist of? Well, proper oral resting posture, is going to consist of the tongue lightly suctioned up to the palate. Do they have the ability to suction? Do you have to work on their ability to suction and then their strength and retention of such suction? Do you have to work on it in a conscious breathing way where you're passively engaging it, or are you actively engaging it? Are you needing to strengthen the lips? Is there a tethered oral tissue component that's blocking you from being able to close? Do you have to get a little bit more elongation in your philtrum so that you can get those lips to close and to seal? Are you working on the orbicularis oris for that seal? Do you have to work on nasal hygiene? Do you have to do active breathing exercises? How would you sequence that? What comes first? The breathing exercises? What comes first? The lip and the strength of such? What comes first? The tongue and engaging in the suction, what muscles are involved in order to engage in an active suction, what skills are required that preference or come before preface you achieving suction. Establishing proper oral resting posture isn't just a sequence of exercises. It's a buildup of all these steps that you need to get to that goal. And so as you're constructing a treatment plan and you're thinking about it, I want that to be a part of it. If it is multifaceted, which all treatment plans should be, most people, at a bare minimum, I have 3 goals on my treatment plan. At a bare minimum, there's 3. And if proper oral resting posture is on every single one of them, and those are all the things I need to consider, how do I fit that in with the other things? What if there's an oral habit I have to eliminate? What if there are goals I'm seeking with the joint, the TMJ, and I want to help them with establishing nasal breathing? How am I putting all these things together? To put all those things together, start making lists of what all is involved, because it's incredibly important. It's going to help you to figure out that treatment plan. Okay, so let's think about it. With a lateral tongue thrust, you do an evaluation. There's a lateral tongue thrust. A lateral tongue thrust is really just an imbalance of posterior lingual musculature. It's either really strong or really weak, or they're struggling somewhere in their lingual musculature. Or sometimes it's like that primitive swallowing pattern that's just been retained. And so where you might not even always see the lateral tongue thrust. There are people who have open bites bilaterally, or sometimes it's a unilateral open bite and you get the thrust more prominently on one side than the other. You might not even see it. You might be something that you have to feel. If you've never felt a tongue thrust laterally, I don't know how to explain it to you, but it's something that you could just feel. This might be combined with poor salivary management. So there's drooling, or like they're messy eaters and like food is everywhere and they're trying to eat, but it's just all over the place. It's in the cheeks, like they get stuff all over. A lot of plaque and build up as far as calculus, like along the molars, because everything is pushing outwards and like saliva is moving things all over the place, and it's just hectic. I want us to take a second, and I will literally allow a little minute before I resume, and I'll check the comments while I'm doing that. But what should come first if we're looking into how we're going to resolve a lateral tongue thrust? Now, lateral tongue thrust is a combination of things, just like improper oral resting posture is a combination of things. It's not in and of itself just a thing, but it could be something that you observe. So now we're going to we're taking something out of an evaluation and we're putting it into planning. What should come first? Should it be swallowing exercises to remediate the thrust oral phase swallowing pattern? Should it be engagement and strengthening of the lingual musculature? Should it be lip and facial muscle disassociation from the swallow? Should it be buccal suctioning strength for that salivary management? What should come first? And what should come second? And third and fourth? There are some cookie cutter programs where you're taking an exercise from every single section. So you'll take an exercise, a tongue exercise, a lip exercise, a cheek exercise. I don't know. You're taking an exercise from every section. So you'll have them doing a little chewing and swallowing like the first day that you meet them. They've got all this dysfunction, but they're chewing and swallowing the first day you meet them, because that makes sense. I don't know. Somehow. Okay. So for some, that might be the first step. But let me know, out of these possible things that you're going to have to work on in the remediation of a lateral tongue thrust, what exactly is it that you think should come first? Let me check the comments just really briefly. I don't know. This thing sometimes doesn't always work to show all the comments, but that's okay. All right. Gave you a minute to think about it. Let's move forward. Here's the answer. Tongue musculature. If a lateral tongue thrust involves deficiencies or overdevelopment in the posterior musculature or any of the lingual musculature, shouldn't we resolve that first? Develop strength, develop awareness, increase the enhanced range of motion. We're broadening, we're narrowing, we're understanding how we're really manipulating the back of the tongue or even the anterior tongue if there's issues there. Getting that first. Then working on some of the buccal suction, salivary management. We got to be able to contain everything, to gather everything, so that once we gather everything in that oral phase, we can do that oral phase swallow without much issue following. Lip and face disassociation can come next, because now we're going to start to bring in simple things. Now we're manipulating saliva with the suctioning, and now let's disassociate and remove the lips and the facial muscles from the swallow so that the tongue has to bear that on its own. And the tongue now, which is strong enough to do so because you've done all the work on the lingual musculature, and now the tongue can start to understand this new pattern. So that you consciously can observe this new pattern, so that you consciously, as the client, can start to feel this new pattern, the difference, the suctioning, you're understanding how everything is coming together. And then, now that we've got the lips and cheeks and whatever, everything is disassociated from the swallow, we should be able to do some swallowing without any of the retraction involved. And so now we're building up to habituation. Now we're going to remediate. Now this is true remediation because we have all the things in place that are going to help us to get there. And I want you to start thinking about it and breaking down everything like that. And I don't want it to be confusing. I'm promising you my goal is not for this to be confusing for you. But the more you start to understand the nuances of what you're doing, this is so far beyond what some of these 28-hour courses are teaching. You need to understand the nuances of what you're doing, why you're doing it, and how it all comes together. That way, when you're treatment planning, it makes sense. It makes sense. You could do this for everybody because you understand how things come together. It's not just I do this exercise because I was told to do this exercise first. It has to make sense. Make it make sense. Okay? When I think about things like how I sequenced that lateral tongue thrust and I broke it down into things, it's always about this tiered phase program that I think OMT is all about. 1, the foundation. Phase 1, we are dealing with the musculature. That's where you should be starting. That lingual musculature, the buccal suction, you are dealing with the musculature. Then you start to coordinate. So now we're doing activities and tasks that are bringing together groups and sets of muscles in a way that makes sense, that we can start to see where the problem was, and we can start to repetitively introduce a proper sequence of coordinated musculature involvement in activities. And then once we've gotten there, so that was all, your suction, your lips and cheek retraction, move it away, whatever, then you can get to habituation, which is now we're integrating this. Now your closed lips, you're making it happen. You're doing it And this is something that's now a new neuromuscular pattern and skill that's going to last you a long time. That's habituation. We want it to become a new habit. We want it to retain. Okay. Planning. Because remember, it was evaluation construction. So we just constructed, talked about those phases. If I'm losing you, please let me know. But the last step was planning. And in planning, you have to understand that shift happens. You always have to be prepared to shift, to pivot, to move, to make change. Because what you think is the plan and how you've got it prepped in your head may not be how it actually falls into play. So I create treatment plans. I love a good treatment plan. I know where I want to go. I know how I want to get there. I am making all of the appropriate steps and taking all of the appropriate action. But that does not mean that they respond in a way that is going to be conducive to me following the plan as I envision it. I might have to go backwards and work on some other things. I might have to say, oh, thank goodness I have a system. Thank goodness. Because if I didn't have a system, I would have no idea where I got this wrong. And you don't even have to say that. Nobody knows that you got something wrong. When you hit a roadblock in your treatment, you have to understand that there's something you need to go back to. And when you go back to that, that's where you start making all the changes. So your plan, I want you to have a plan. I ideally envision we're going to start here, here, and here. This is their deficiencies. We're starting here. The lingual musculature, we're starting here. Then we can go to whatever is next. But if I didn't master everything here and I try to skip ahead, and then I'm like, oh man, they're really struggling. Like, why can't they get this coordination going with the tongue? It's not bowling. Like, I don't understand where I missed something. I can't get the cupping for the management of the saliva that we're trying to move. Oh, I didn't do any work on them with cupping. I need to go back. I have to revisit that. Oh, I didn't coordinate with them, the musculature here. I have to go back. So your plan, I want you to have and really deeply envision it. There's a lot of things I see like coming in advance with certain people I'm working with. I'm like, oh, okay, I see this dysfunction, this dysfunction, this dysfunction. I know how that's going to come into play. But the same thing that works for Susie doesn't work for Jane, doesn't work for Emily. Emily might have more problems engaging, might have more problems. Emily might have sensory processing issues and is really struggling to really get certain tasks and certain things. Jane might have a hyperactive gag reflex that I need to address and pivot entirely away from most of the things that I was doing to deal with that. Be prepared for a shift. Be prepared for things to go in a way that you were not fully anticipating. Okay. And then when you do that planning, make sure you give them an actual plan. There are so many things that I've seen now since I've been like working independently and loving that, but working independently and talking with people and really getting my pulse on what's going on with others. And then they show me how their treatment plans work or what they do after an evaluation, how they kind of put everything together, what an evaluation report looks like for them. And I will never understand treatment plans that are really just like a bulleted list of what's wrong and how it's just a bulleted list of what's wrong and how just Myo is going to be the fix to it. How is Myo going to be the fix to it? What are our realistic goals here? What are the anticipated outcomes? If you don't know, they don't know. I'll never understand that. How do you hand somebody a treatment plan that doesn't have that? And it really lacks informed consent. They don't understand what it is they're working towards, what potential risks are. I'll never understand that. If your whole treatment plan or what you give a client or what you give a referral provider is just the bulleted list of like, oh, this is wrong, this is wrong, this is wrong, these are the things that I found in the evaluation, we're going to do Myo, it's going to be 12 or 14 sessions, and yay, hooray. Wonderful. I'm sure nobody wants to read the lengthy plans and reports that I put out, but I'll tell you that every single time I've sent one, every single time, to a new provider, somebody who's not accustomed to how it is that I work and what I do, everybody's impressed. Whoa, all the details are here. I understand exactly what it is that you're looking for, where you're going, what you're going to do, how you're going to get there. Highly impressed. Look forward to working with you. Awesome. Look forward to working with you too. But I have to know and understand deeply where I'm going. And for something that other people don't understand, nobody understands what myofunctional therapy is. And I'll tell you, there's a whole lot of people who don't care. If it seems as though you, as a provider, as a person who specializes in this, also doesn't care because all you're giving is a bulleted list of what's wrong, I don't anticipate other people caring because you sent them a list of, oh, look, I found all these things wrong. What are you going to do about it? Myofunctional therapy. What does that mean? Nobody knows. And so it doesn't demonstrate your understanding of your own individual protocols. You might as well just cookie cutter put that out for everybody, have one report and make that the report. And you've got to put in some sort of outline of where everything kind of originated and began. I always put a background into every single report I do. I always put a background. You came to me and it was this. You had a history of complicated vaginal birth involving forceps, lack of breastfeeding due to poor latch, motor skills, worked with an occupational therapist because there were delays in the motor skills and the core strength and function. Currently working with where have you been? What have you done? Where did all of this originate from? Great. That's put aside, the background. And then look what I found in my evaluation. These are the muscles that I found that are problematic. This is the function that I found that didn't work well. These are the compensations. These are the patterns. These are what's happening. And this is where we're going. We have to do this, and this as our realistic set of goals and expectations. And to get there, we're going to use, what are your protocols? What are your systems? What are your modalities? Are you using breath work? Are you using cranial nerve integration? Like what are you using? How are you getting there? And what's backing up these statements? Just think about that. Just think about it. Treatment planning it's extensive. It should take you time. Let's get into my sequence because I think this is really important. This graphic is old, but the content itself is very relevant. Habit elimination precedes everything. I can't do anything if you have a thumb, a digit, an object that is in my workspace. I wouldn't, as a dental professional, I haven't worked clinically in years, but I wouldn't, as a dental professional, do any sort of work if you had something in your mouth. Can you please remove your thumb? That way I can get started. I need you to remove your thumb or remove the object or to eliminate that thing that's in the way that's blocking us from being able to get started. So habit elimination prefaces everything. Not all types of habit elimination. Things where there is like an actual thing to be removed. If it's tongue sucking has to be done during a myofunctional therapy program because I cannot eliminate the tongue from the area. So let's just think critically about the statement that habit elimination prefaces everything. Just think critically about it, and I promise you it'll make sense what habits you can deal with before and what habits you have to deal with during a program. Basic lingual function is the foundation. I can't expect you to establish proper oral resting posture. I can't expect you to have the skills that it would take to have a lip seal. I mean, it's tongue, palatal seal, sorry, to have a palatal seal. I can't expect you to manage saliva, liquids, foods, or anything in the oral phase if I haven't mastered your basic tongue functional skills. If I haven't checked off every box that's within that. So, where's the deficiencies? Are they unable to establish cupping, suction, retraction, narrowing and broadening, lateralization, elevation, protrusion? Like, where is the deficiencies? Not where they're really good. Oh my gosh, they can elevate their tongue. Great. You don't have to do any exercises that deals with elevating the tongue. Why would you? Because it's on visit 2? What? They already can do that. Move on. What are the other skills that you need to work on? Look at your evaluation. This will dictate to you what your plan should be. Seal and suction, palatal seal. I need that to be done before I go on to anything else. Now, can you mix lip strength in with your lingual skills? Sure. Everybody likes variety. What I'm really doing in a lot of my programs, honestly, habit elimination comes first. Cranial nerves, any sort of primitive reflexes, like deal with that stuff first. Energy work, if I'm dealing with any of that, that's happening first. Then lingual skills, then palatal suction. And I tend to be more, I tend to be able to move quicker in that way. Okay. So lingual skills, palatal seal and suction, lip strength, engagement, facial muscles, dealing with any asymmetries, that counts in there, that lip strength. I'm just dealing with everything that's not the tongue, all the supportive external facial musculature. Soft palate is also in there in that lip strength. I should really make it like oral facial strength. But this is also an old graphic from when I used to teach with a previous course. Then you get suctioning. Buccal suction, anterior suction. How are you manipulating? Air. How are you manipulating air first? Then graduate to liquids. Then you graduate to solids. How are you manipulating these? Oral phase swallowing. How are you manipulating or remediating? Sorry, how are you remediating the dysfunction that existed in the oral phase of their swallow? And then you can do the penultimate. I always call mastication the penultimate. It's a combination of so many different things. You need all those lingual skills. You need the lip strength. You need to be able to suction. You need to be able to properly swallow. Chewing, it should be at the top. It shouldn't be what you do day one. Hi, I just met you. I want you to do a cracker swallow. Based on what skills? What skills have prefaced this? In what way have you prepared them for this moment? Don't tell me I need to go run a marathon tomorrow. It's not happening. I won't be successful. Tell me you want me to run down the street, do a 500-yard dash every day for the next 10 days. Then from there, we're going to do 1,000. Then from there, 1,500. Then from there, let's go even further and further and further. We're going to build and build and build and build and build and grow until we get to where you can successfully meet the metric. Just make it make sense. Why is breathing and nasal hygiene up there? Breathing and nasal hygiene are up there because that's really also foundational, and it can happen at any point in time. More often than not, it's prefacing in my programs all of the lingual skills. So we're going into cranial nerves, we're going into breathing, we're going to nasal hygiene. Like before I ever start anything at all, we're dealing with that stuff first. Then we'll come into myo, because myo is, again, and I'll always say this, the least dynamic thing I'm doing. Allow yourself to appropriately sequence. Your sequence doesn't have to be my sequence. Your sequence can be your own sequence, but it has to make sense. You have to have some cognitive understanding and awareness about the nuances involved with working with people's dysfunction. Otherwise, you're going to make them more dysfunctional. If you don't have a sequence, it's kind of like answering the question, tell me you don't understand what it is you do as a myofunctional therapist without telling me you don't understand what it is you do as a myofunctional therapist. You answer that perfectly by saying, I follow the cookie cutter program. I have a lot of different projects up in the air. A lot of different projects up in the air. It's really sad the amount of things that I'm working on, like how many things and why. But what I do want is to make sure that people understand this in detail. And so I'm going to plan something in the future where we do a nice small cohort of people who are getting on a Zoom, and you can see me go through an evaluation and a treatment plan and how I would build all of that, and then what I would plan for the sessions based upon that. We can do all of that in a small group in detail. Just email me. Send me an email. Just put in the subject of the email, like treatment planning or whatever, that you want to be a part of that, and I'll kind of coordinate it. It'll probably be sometime next month because I have a lot going on right now. But it'll probably be sometime next month. And I think ideally, if you're still a little confused or you'd like to see that in detail, allow me to put you in a small group where we can kind of go over it together. You can ask your specific questions and we can treatment plan in unison, and you can understand what it is you're supposed to do a little better. Okay? Good. I don't see any comments, and that's okay. Sometimes I think the comment like link or section or whatever is broken. If you do have any questions, YouTube will open up the comments after this is posted live. Put it in the comments. Feel free. Shoot me an email with whatever the questions are. It's more helpful to others if you put it in the comments, though, because then your question might be somebody else's question, and that helps them as well, so that we're all growing together. But I've really enjoyed being here with you. I hope that, you've gotten out of this something that you can take into your treatment planning sessions, and that you are as successful as you are looking to be, and even more so, exceptionally successful, because that's what we're aiming for, is excellence always. All right. It was such a pleasure to be here with you. I'll see you next time. Bye, friends.